Hi, my name is Cheryl Moore, and today I'm going to go through with you a few things about autism spectrum disorder. First, I'm going to describe a little bit about what autism spectrum disorder is as defined by DSM-5. I'm going to identify and describe some tools and strategies for identification and diagnosis. I'm going to explore a few of the characteristics of ASD, including some typical patterns of exceptional development or coexisting or comorbid conditions. I'm going to briefly discuss some historical issues associated with the diagnosis, and then we're going to compare some differential approaches to intervention and some treatment of ASD. So first, let's start with the definition of autism. What exactly is the definition according to DSM-5 of autism? Well, to gain a diagnosis, first of all, individuals must be observed as having restrictive, repetitive patterns of behavior or interests or activities as manifested by at least two of the following. 1. Stereotyped or repetitive motor movements, use of objects or speech. For example, simple motor stereotypes, lining up toys or flipping objects is very common. Echolalia, not as common necessarily, but also idiosyncratic phrases they say over and over again. These children may get overstimulated or overloaded at times, maybe for a reason that you may not think of. Why are they getting overloaded? Or they seem to get upset all of a sudden. You may not realize why, what is the reason for it, but all of a sudden they're upset and you can't find a reason. So this may manifest as repetitive motor movements. Some examples are hand flapping, maybe like to spin. Sometimes they just like to spin around in circles in the middle of a room. But sometimes it may be in a chair and they like the spinning movement. Or they sit and they rock. Or maybe they like to sit possibly on something like a ball and they like to bounce. There are some pros to this and there are some cons. Some of the pros to this are it can reduce their stress level. Especially in a classroom. It can reduce their stress, it helps calm them down. But some cons to this, and I've seen this as an educator, is that sometimes they're tuning out what's around them. A second thing is they have an insistent on sameness. They like routine, they can get very inflexible, and it can disrupt their entire day. They don't like their daily routines disrupted in any way, and this can upset them. And they also may get to the point where it disrupts their entire day so much that they can think of nothing else. A third item on here is they become highly restricted, fixated interests on certain things, strong attachment to items, or what we would call a preoccupation, with unusual objects. They may focus on a certain item carried around. Some of these things might be, let's say, a dinosaur toy. They may want to keep it in their pocket. They have to have it with them at all times. They sleep with it. They bathe with it. Maybe they have to have it in the car. They have to take it to school. They have to take it in a restaurant. It must be with them at all times. If they don't have it, they get very upset. They may like to hold it in their hand. They might caress it all the time. And this sometimes can be a good thing as it calms them down. However, if they drop it, they lose it, they can't find it, they become very, very preoccupied for it. They must have it. They've got to have that dinosaur, not a different dinosaur. You can't go to the store and replace that dinosaur. They must have that specific dinosaur. Nothing else matters. Number 4, they might have a hyperreactivity to sensory input, or even an unusual interest in sensory aspects of the environment, or an indifference to pain or temperature, adverse response to specific sounds or textures. Maybe they don't like things that are very rough, but they like things that are very soft. Maybe they like to smell things. I've seen a lot of children have to smell their food. Every single food item on their plate, they have to smell it before they even taste it. Or they have to excessively touch everything and feel the texture of it. They have a visual fascination with lights or movement. An example of this might be in school or in church and movie theater. They might put their fingers in their ears to block out that excessive noise. It's too much stimulation, too much is going on, or the noise is too loud. For some of these children, noise actually hurts. And for us, we're like, well, yeah, it's a little loud, but it's okay. We're in a movie theater. You know, there's a lot of people in church, and maybe they've got the microphones on at the front. It's a little loud, but you don't seem to find it unusual. But in reality, they're very sensitive to sound, and it actually hurts their ears. They get overstimulated. It's just too much. They can't handle it. That's one thing we need to take into consideration. So some screening tools that we can find online, both as parents, both as educators, whether we're a general educator or a special educator. Some screening tools are the PEDS or the STAT. I do have links on the screen and in my references at the end. The PEDS is Parents' Evaluation of Developmental Status. It's a very accurate test. It promotes, a good thing is it promotes family collaboration. So it wants parental collaboration. So whether you're a parent or you're an educator, it wants parental collaboration, which is a good thing. Parents know their kids. They're with them all the time. It identifies children from 0 to 8 years. There's additional tests for screening through the milestones as they get older. It has an additional test for developmental follow-up assessment. The website offers automatic scoring, which is great for both educators and families. So it will explain things to you, gives you a summary report, referral letters. You can use a test alone or with other tests in conjunction. Parents can answer questions online. That's a time saver for everyone involved. And it has training plans for parties that are interested, both parents, educators, etc. Con, of course, access primary developmental concerns. So it doesn't always address everything you want it to, but remember, these are screening tools and assessments. You can't stop there. You have to be able to go further and get other people involved. So the STAT test is the screening tool for autism in toddlers and young children. It's an interactive screening tool, which is always wonderful. We love things that are interactive, both as parents, and I am a parent of a child who's on the spectrum and a grandparent of a child on the spectrum, as well as a special educator. So we always love things that are interactive. It assesses key social and communication behaviors, and we do know that children on the spectrum tend to have difficulty in the social aspect in their lives and communication many times. This can identify children as early as 24 months, which is very early. Sometimes we don't identify children until they reach school age. So unless you're a very proactive parent or you're a parent of multiple children, you don't necessarily notice things about your child that we discussed through the DSM-5 evaluation until they reach school age. So this is a good tool to use. It's training, online, web-based instruction, and it's quick and easy. Some cons with this: it's used primarily with 2-year-old children. So as early as 24 months, which, younger than that, it's very difficult because children can have some delays. So we need to be very careful when we identify young children. And this is primarily for community professionals. So not necessarily for parents or family members, more for community professionals, educators. But that's okay. All right, so the next one we have is the GARS. Again, I have some of, the websites on here for you. Some pros with the GARS: it's used for diagnosing individuals aged 3 to 22 years. It estimates the severity of the child's disorder because it has subgroups. So some of the subgroups are the stereotype behavior that we mentioned with the DSM-5, communication, social interaction. Then it breaks down into subscales. So it matches well with the DSM-5, which is wonderful. That's what we use for our diagnosis. Structured parent interview. Again, we want parents involved as much as possible. It includes a booklet with instructions, objectives for children who have been diagnosed, and can be completed and scored in 10 minutes. And it determines the strengths and weaknesses of the child. And when we have children in school that have been diagnosed with autism spectrum disorder, that is one thing that we always look for. What strengths do they have? What weaknesses do they have? So that we can go ahead and guide that child and use interventions to help guide them in their classroom, and how we can strengthen the weaknesses that they do have and work off of the strengths that they have as well. Okay, and the GARS, is the Gilliam Autism Rating Scale. And then we have the CARS, and that is used for diagnosing individuals over 2 years, and primarily under age 6. It has 14 main domains. The 15th domain rates general impressions of autism. It's indicated mild to moderate autism. Questionnaires for parents and caregivers can be given quickly, and it has a 4-point rating scale. Some cons with this, though, are that it's oversensitive for young children, and it can overdiagnose. So it does not have a parent questionnaire. So this is one that may not be the best one as far as a diagnostic tool, and it has a weakness in identifying individuals that are higher on the spectrum. So even though we do have this one down as a diagnostic evaluation tool, it's not necessarily the best tool. We're not saying it can't be used, but there are others out there, and there are more than I've mentioned, of course. And of course, you always want to seek the help of a professional pediatric developmentalist, someone who specializes in autism spectrum disorder, to help you. You should never diagnose on your own. This is just a brief look into some tools that can be used. Now, some typical patterns and some coexisting conditions that can be seen with autism spectrum disorder, and we do see it as educators, and there are some differences. A common one actually is ADHD, or attention hyperactivity disorder. There's some general indicators. Sometimes we see social communication. Kids on the spectrum, guess what? Social communication difficulties. Sometimes they both have obsessive compulsive disorder. That is the same for both. However, the things that differentiate from autism spectrum disorder are, when you have ADHD, there's a lot more hyperactivity and a lot more inattentiveness. So there are some differences. We need to keep that in mind. But if you have ADHD, how does this affect you if you have autism? Well, you can be restless. It might increase the need for routine. You need more of a routine now. So we need to keep that in mind if you have ADHD. Some students we see with autism spectrum disorder also have anxiety. So now they have excessive anxiety, excessive fear, excessive avoidance of things. They have increased in sometimes aggression or body reaction. They're constantly worried. But how does this differ from autism? They constantly worry. They have more social anxiety because anxiety is a psychiatric disorder. Autism is not. You need someone to diagnose them separately. They are two separate conditions. How does this affect the functionality? Well, now you're more vulnerable to stressful situations. You have even more fear of change. Your social relationships are even more affected. So, commonality in individuals with ASD if you have anxiety, social phobia, reduced participation in social activities. Autistic children, they do want to get in there and socialize, but they don't always know how. They're not sure how to progress in a social situation. It's not that they don't want to, they just aren't sure how. Children with anxiety are afraid to. We need to take into consideration that children on the spectrum can have separate disorders, and how do those separate disorders affect them? Some students with autism spectrum disorder also have sensory disorders. So if you look in the first column, a sensory disorder, they have a constant need to jump on a trampoline. more spinning, more swinging, picky eater. They don't like the way things feel in their mouth. Autistic kids sometimes have that issue too. Maybe they're undersensitive. Commonality with individuals with autism. Yeah, guess what? They don't necessarily know where their body is in space either. If you have a sensory disorder, you can have the same problem. But the difference between a sensory disorder and autism, sensory integration is a neurological condition. Autism spectrum disorder is not. But sensory disorders are very typical with children who are on the autism spectrum. So we need to keep considering the fact that just because we have an autism spectrum disorder, if we're showing symptoms of other things, that doesn't mean that this child does not have ADHD. They do not have a sensory disorder. They are not bipolar. It is very possible that they have another disorder. So as parents, as grandparents, caregiver, whatever role you play, or as a general educator, you need to realize this child may have that coexisting condition along with autism spectrum disorder. Don't discount if you're seeing something else going on. There's no textbook autism child or autistic child. There are other things that can exist along with the autism spectrum disorder. So some historical issues that we have seen previously is decades ago, back in the 40s, children with autism were thought to have been mentally retarded. They thought that parents were either helicopter parents and did everything for them, or they thought that parents neglected their children. There was a doctor called Leo Kanner that began observing a group of children, and he noticed that these children also had developing speech issues, and they didn't socially interact with their peers. And he noticed that they engaged in ritualized or repetitive behaviors, and they excluded from other activities. He noticed that they had difficulties with transition. They couldn't go from one thing to the next easily. They didn't like change in routine and their schedule. They experienced regression in their functioning. They weren't gaining skills. They were losing skills. And he had descriptions that he described to parents and things. And he said they were placed in institutions, kept out of the public eye. They said that they had these refrigerator mothers that were responsible for the symptoms observed in these children. They blamed the mother. They felt that the children had poor attachments to their parents. Their mothers did not give them the love they needed. Sometimes like I said, sometimes it was too much love, then it was not enough love. So basically they blamed the parents. It had to have been the mother's fault. It's always the mother's fault. But today, we know that's not the case. They don't know why necessarily that there seems to be an increase in the rate of autism, other than we know that the diagnosis, the way we diagnose children has gotten better. We've narrowed it down more so that we can see the differences in children on the autism spectrum. And because we have narrowed it down and we see these little things that these children on the spectrum do, certain things they do, that we have narrowed it down so much that it's not necessarily that the rate is increasing because of something. It's just that we've narrowed it down so much and we've pinpointed the criteria that more are just considered on the spectrum. So it's just higher than it once was, or we had once thought it was to be. And they feel that it's also a combination of genetic and environmental factors. And where once I know my son, who is now 25, and at that time I believe it was 1 in maybe 96 children who were diagnosed, it is now 1 in 59. And that is mainly because we have narrowed down the criteria so much, and we see so many things that they do differently, just like we've narrowed down anxiety disorders, sensory disorders, bipolar disorders, that we are now able to diagnose it easier. So now it affects 1 in 59 children around the world, all cultures of the world. It doesn't discriminate, but it is 4 times more likely in boys than in girls. And approximately 10% of the children with ASD have identifiable genetic or chromosomal disorders, and currently no cause. And of course, there's no cure, which is why we need to build on strengths, find their weaknesses, and then build on those weaknesses, which leads us to our approaches to intervention. So I have a list here of different approaches to intervention. Okay. And one of them is social narratives. So I picked some to talk about just briefly. So social narratives are where we build social stories, and we talk about social situations. We give them pictures. We can act it out to help the autistic child understand how we act out certain situations. Then we have self-management. We teach them how to keep track of their behavior. Are you getting off task? You're getting distracted? Did you stop what you were doing and started, playing with your dinosaur again? Or could your dinosaur just sit on your desk while you're working? And we teach them how to maybe every 5 minutes, are you on task? And we teach them how to self-manage their behavior if they are able to do so. Some children are not able to do that, but some are, and we teach them how to manage themselves. Video modeling is a good way to intervene. That is when you could have a peer model how to do something. Maybe it's how to make something, how to build something, any of that. And then they watch the video and they do it. Visual support could be using a PEC system, which is something that helps them learn how to say certain sentences with words. It could be a visual schedule. Another one could be peer-mediated instruction and intervention. And that peer-mediated instruction and intervention is simply working with your peers, and they help you in the classroom. They help you do things. They help you in social situations. And this is usually specific peers are chosen for this actual purpose. And these are just a few of many different ways of intervention. And that you see there's a list of them. There's many, many ways that can be used to intervene with these students. And you have to really differentiate with every different student. And I listed many of them also, and the reference is also listed here on this slide so that you can go to the website if you choose and look up the different ones, because they all have to be chosen for each specific student. Differential approaches to treatment, different types of treatment. One of them that is really common is ABA therapy. This is a specific therapy that is widely used, and it encourages positive behavior and discourages negative behaviors to improve a variety of skills. This progress is tracked, usually have someone who is certified in this area. They work specifically with the child. Sometimes it is they work with them to help them eat different foods. Sometimes it is to help them with an unwanted behavior. Maybe it's to get them to do a certain task. Sometimes they work with them with speech. We also use assistive technology like the Picture Exchange Communication System, or PECS, to help with them communication skills, learning to speak sentences for their wants and needs. Also, developmental individual differences, relationship-based approach, or floor time, when they use their feelings and relationships with caregivers to focus on how they deal with sights, sounds, smells, because sound can be very difficult for these children, even smells sometimes. Treatment and education of autistic and related communication handicapped children, or TEACH, uses visual cues to teach skills. An example is picture cards can help teach a child how to get dressed by breaking information down into small steps. Not all these children can follow 10 steps. You start with 1, then 2, then 3, and move on. Occupational therapy, social skills training. How do they interact with their peers? They need to learn. They don't always understand social situations. They do not always understand facial reactions, or if someone is sarcastic to them, they need to learn them. So we have to teach them social skills. And they do this by specific training. We can partner them up with a peer and a professional, and we literally role play and teach them how to interact. Speech therapy, if they have communication skills, is very helpful. A lot of ABA therapists will also do this sometimes, depending on their needs and also the ABA therapist certification. And then sometimes diet and then medication if needed. And here are my references if you want to look up any of the things that we talked about today. Thank you.